And good morning, everyone. I see there's an exciting meeting happening in Madrid. Now I am in Algeria for another meeting, Algerian Ecology Congress. This another nice one happening here, and I want to extend greetings from my colleagues from Algeria. This shows how quickly urological technology is advancing around the world, and I want to thank Javier and organization for including me online from here. Today, I'll talk about preserving ejaculatory function during BPH. Our patients prefer uh, fewer sexual side effects in managing lower urinary tract symptoms. They care most about avoiding sexual dysfunction. In fact, up to 90% of men will choose treatments that avoid side effects, sexual side effects, even over the non-sexual ones. This is a landmark study, in my opinion. We still don't fully understand the exact causes underlying ejaculation dysfunction and how to prevent ejaculation disorders developed after BPH treatments. These sexual disorders and ejaculation dysfunctions can include pain, the less seminal fluid, and retrograde ejaculation. And there is clear need for terminology standardization in addressing ejaculation dysfunction because it is even not possible to read the studies. They all far from standard approach. We have many experience, but they are all almost in expert levels. Our main aim for BPH treatment is to reduce symptoms, prevent the condition from worsening, and improve the quality of life of our patients. All treatments for BPH disrupt ejaculation to some extent due to the inherent changes in prostate anatomy over time. Each treatment works in a unique way to improve urine flow mechanism, but they also disrupt ejaculation in different ways. In surgery and topic intervention, surgery complication arises from damage to surrounding tissues. The excision of the entire prostate and damage to surrounding prostatic tissues are inherent parts of effective prostate interventions, often compromising ejaculatory preservation. The ambiguous anatomical landmarks during the endoscopic intervention complicating the situation and precise preservation is the key structures responsible for its ejaculation. Anatomic endoscopic enucleation of prostate or what else have several advantages over traditional ERP. The bladder removing obstructive prostate tissue, lower bleeding risks, and recovery times. However, enucleation techniques, while improving symptoms, still pose a risk for retrograde ejaculation. According to our basic ejaculation depends on the bladder neck contraction and the movement of the sternum. Bladder neck, internal sphincter, external urinary sphincter, and urethra are all components of this process. However, the Jill Vernett's cornerstone study claims, which we will agree that bladder neck contraction is not necessary for antegrade ejaculation. This important determination, the muscle around the variable, especially its upper part, is utmost importance, and this area is defined and described as a high-pressure ejaculatory area. A better understanding of ejaculation physiology has enabled the emergence of modified surgical techniques. Sorry. And uh, here in this video, I'm I have to put these voices in order to tell you explain better. Here in the video, we can observe the endoscopic anatomy of prostate. Anatomical endoscopic enucleation has brought a new perspective for prostate surgery. We accept. However, removing the completely from the capsule doesn't always better outcomes by preserving product structures like colliculus, with montanum and ejaculatory ducts. We can achieve more effective results. In this tool, just a few days before, even than the most of the surgeons before, stayed off to 7 o'clock with that in neck. Uh, the common approach in ejaculation preservation techniques for an 8 o'clock, starting with the bladder neck, looks more usually good. New techniques aim to preserve ejaculatory function during BPH surgery. Just as an example, Rao's method, ejaculatory food collapse technique, are designed to protect BP structures, and the methods have shown promise with up to 90% of patients preserving ejaculation. Really worthy to mention after this operation, because sometimes nowadays, after this laser industry and laser prototomies, some urologists claim that instead of medical therapy, we can move to anatomic education with the lasers early, which is not a scientific way of approach. But so if we are thinking like that, we have to think about population preservation as well. And despite being these techniques are far from standardized and have not been validated in large tracts, the efficacy of modified laser enucleation techniques in preserving ejaculatory functions is evident, though only a limited number of studies have reported results. So between laser tech, only a few laser enucleation studies have explored techniques to preserve ejaculation. These studies show that making incision at specific distances from verumontanum helps protect ejaculation. So, ejaculation preserving photoselective vaporization. It preserves the bladder neck muscle fibers, precollicular tissue, and the paracollicular prostate tissue. We focus on these tissues. And the other one, known, well known than the others, food preserving technique during the food, find as the paracollicular and tissue 1 centimeter, more than 1 centimeter proximal to the verumontanum. The overall bipolar enucleation shows better outcomes compared to volume. Notice here in that the impact of blue volumes in the patient rates favoring bipolar over polyp in this baby's analysis. And these are ejaculation dysfunction between different basic techniques. Uh, uh, the advantage of thulium has a penetration 0.25 versus holmium at 0.4 meters, and continuous wave output reduces the damage to structure. And the main holmium laser drawback is the pulse output causes more tissue-rich group and requires greater stress risking damage to surrounding tissues. However, again, I have level of evidence low in these proposals, as they are just search questions. And this apart from our systematic review, mostly high quality, but not in comparative studies are making in this important and usually very uh, 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 we see so much BPH patients in our practice, and it's surprising not to have such kind of collaborative comparative studies. As we haven't comparative studies, what happened? A group of experts came together and a good job here proposed a concept on how to preserve ejaculatory function during prostate surgery. They divide prostate in three regions: base, middle, apex, based on distance from their montanum. Their recommendations in protecting the area around their montanum, maintaining the integrity of urethral lining, especially the posterior side of urethra, and preserve that side. In my is again an opinion, not an ensuring the tissue removal. Things are the ambiguity, the terminology of ejaculation dysfunction. The field in 2024, we have this limitation. The standard and the given style of the patient outcomes, the follow-up between the limited number of study, um, some emerging treatment options. Actually, they are not emerging because for the last few decades, we are minimal invasive prostate treatment modalities, and these modalities in rectum, urocoagulation, they are all but come with higher treatment rates. Just an example, urology has a more than 13% treatment rate at 7 years. The other thing from my clinical practice, prostate PSA level, body mass index, and estrogen experience utmost important here, and we don't have data on these factors. For example, in my clinical experience, uh, preservation is more for small and medium size prostate, even high for large prostate, but also the technique that we have to use for small prostate, medium-sized prostate, and large prostate are not same. As a conclusion, say that how can we widely recognize and we need to create a standardized technique for preserving ejaculatory function during the technique should focus on protecting the montanum and surrounding effectively. Treating BPH would help ensure a balanced symptom relief, preserving ejaculation. I thank you for your time and opportunity.